Welcome to our podcast, Multiple Myeloma Morning Commute, standard care for the newly relapsed patient. Morning Commute is developed in collaboration with At Point of Care and Projects in Knowledge and is part of a continuing medical education series. This independent CME-CE activity is supported by an educational grant from Oncopeptides and Sanofi Genzyme. In this episode, Dr. Ravi Vij and Dr. Thomas Martin discuss treatment of multiple myeloma in patients who have relapsed. Most of these patients are on maintenance therapy, so how do you select the right regimen for them? The good news is that there are many to choose from. Information about the faculty and disclosures can be found at morningcommutepodcast.com/multiple myeloma 1. You can use this link to receive your credit and evaluate this program. The URL can also be accessed in the episode notes. Dr. Vij is a professor of medicine in the Division of Medical Oncology at the Washington University School of Medicine in St. Louis. Dr. Martin is a professor of medicine in the Division of Hematology Oncology at the University of California, San Francisco. I am Candace Hoffman, managing editor of Morning Commute. Dr. Vij will begin our discussion.
Hello, my name is Ravi Vij. I'm a professor of medicine at Washington University School of Medicine in St. Louis. Today I have with me Dr. Thomas Martin, professor of medicine at UCSF in San Francisco, and we're going to be talking about the management of early relapsed multiple myeloma. Welcome, Tom.
Thanks for having me, Ravi.
So today I think what we have to talk about is how you approach your patients with myeloma once you see their disease is coming back. Most of the patients have been on maintenance therapy these days. And so how do you approach these patients when their disease is coming back?
Well, thanks, Ravi, for that question. I think the space in the myeloma field right now is so crowded with medications. It's really actually fun to select what we think the best regimen is, especially for first relapse. There's a couple things that I take in consideration with first relapse. What you initially said is a lot of patients are on maintenance. So if they're on a maintenance-based therapy, it really depends on what that therapy is. And then I would consider them refractory to that therapy. Most of the time it's lenalidomide. Even if it's lenalidomide at 10 milligrams a day, I call them refractory to lenalidomide and I try to avoid that. And the second is what else they've been exposed to in frontline. Currently, very few of us, I think, utilize CD38 antibodies at frontline therapy. And thus, it's a great drug to select as part of your regimen for early relapse therapy. And in early therapy, I always try to use a triplet-based therapy, a CD38 antibody plus dexamethasone and plus a third agent. And the third agent will basically be based on what they might be refractory. And if they're refractory to lenalidomide, then I will choose potentially a proteasome inhibitor-based therapy, perhaps bortezomib, like in the CASTOR trial. So bortezomib, daratumumab, and dexamethasone. Or I might choose carfilzomib, like in the CANDOR regimen, which is carfilzomib, daratumumab, and dexamethasone. The CANDOR trial just showed that the daratumumab plus carfilzomib regimen was associated with a PFS of right around 28 months for 1 to 3 prior lines of therapy, which is quite amazing, actually. But the other option is to do pomalidomide, is to choose pomalidomide. It's an oral medicine and it's easy. And daratumumab plus pomalidomide and dexamethasone, in my mind, is another great regimen to choose as first relapse, even in those that are len refractory. And that also has been recently tested in the Apollo trial. That PFS was a little shorter, but it was people who had second or more prior lines of therapy. It was 2 prior lines of therapy or more. So it was a more heavily pretreated, and that's why the PFS was a little shorter. I'm curious, what do you choose for your first go-to and first relapse?
I think we think along the same lines. I would say that recently for patients who have symptomatic relapse, have PET positive relapse, the use of daratumumab with pomalidomide and dexamethasone has been my favorite regimen, and I am starting to use daratumumab with carfilzomib and dexamethasone as well. And I think that it's a little difficult for me to decide sometimes which way to go. I tend to give patients who have very aggressive relapse often the carfilzomib-based combination with daratumumab because you have ready access to IV drugs. Sometimes getting the pomalidomide can take a few days. And then the other thing is that if you don't need that aggressive approach right at the beginning, then you can go with the pomalidomide-based combination, and it really becomes very simple for patients. Once they're in 6 months, they're just coming in once a month to get, these days, just an injection into the skin, which takes all of 5 minutes to give, and then they're just taking pomalidomide by mouth at home. So I think it is certainly more convenient. Now, I must say that in my own practice, for patients who have biochemical relapse, I'm using a fair amount of elotuzumab with pomalidomide and dexamethasone as well. And I think that the regimen does, for few patients, produce fairly prolonged responses. And I see little downside in these early biochemical relapse patients to see if one can have some durability with an elotuzumab-based regimen before going to a daratumumab-based 3-drug regimen. In few cases where patients really want an all-oral regimen, either because they are older or they're having a biochemical relapse and working and don't want to disrupt their work, I may even try an ixazomib-based 3-drug regimen. They, again, work for usually shorter periods of time than the daratumumab-based regimens. Do you use any elotuzumab or ixazomib in your practice?
Yeah, that's a really interesting question, especially now when we're on the tails of, hopefully the tails of the COVID crisis. And a lot of patients actually didn't really want to come to the treatment center. And so, yes, we do oral ixazomib, pomalidomide, and dexamethasone as a triplet. And the other triplet that I actually like, and we published this together with the Moffitt group in Florida, is pomalidomide oral cyclophosphamide in dexamethasone. So pom-cytoxan dex, in my mind, is a nice regimen. When we published it a few years ago now, probably 4 or 5 years ago, the PFS was just under a year for that triplet combination. But for early relapse patients, I suspect we'd even get longer. It tends to be a really well-tolerated regimen. I think, when you combine Pomalyst with cyclophosphamide or Pomalyst with daratumumab, the biggest side effects tend to be blood count suppression. So you just have to watch their blood counts, and you have to dose adjust as needed. And often I'm going with right from 4 to 2 milligrams of pomalidomide for my dose adjustments with blood count suppression. When I do it pomalidomide with ixazomib, or sometimes actually with bortezomib, and that was the Optimism trial. Paul Richardson presented that Optimism trial, which was pom bortezomib index versus bortezomib dex. They actually saw in first relapse patients an overall response rate of just over 90%, and a PFS that was actually quite good. It was over 16 months. I think it was close to 19 months as first relapse. So that's a nice regimen too. You get less blood count suppression when you combine it with those PIs, POM plus a PI. But the thing you always have to worry about is the neuropathy. That's the thing you worry about.
So we've talked about, the pace of the relapse sometimes informing our decision on choice of therapy. Obviously, there are other factors that one takes into account as well. Sometimes, do you take risk stratification, the cytogenetic or the FISH test results of a patient into account when deciding your own second-line regimen?
Yeah, that's a really, I think, a really important point and an important question. And so if somebody has a adverse cytogenetic feature or FISH feature at diagnosis, then that person I am going to treat very aggressively. And I wouldn't use elotuzumab, and I wouldn't use oral regimens. Those are the patients that I would, in fact, combine our best regimens, which I think are CD38 antibody, with carfilzomib or pomalidomide, no doubt about it. And I probably would try to treat them to get them into as deep a response as is possible. And so, yes, I do try to treat them a little bit more aggressive. If they hadn't had a frontline transplant and they were a transplant candidate, I would consider it after first relapse. I would consider a transplant at that time if I didn't do it frontline for the high risk group.
Certainly. And I think another group of patients that are functionally high risk are those who relapse early. And for them too, I think going and being aggressive is important because I think those who relapse early, though they may sometimes not have the traditional biological characteristics that we associate with high-risk myeloma, they've declared themselves to be high risk themselves. So another question that I would have is that obviously we live in the ivory towers of academia. People out in the community are often faced with individuals that are in their 80s. I've seen obviously patients even in their 90s with multiple myeloma. And there, I think that sometimes you have to give up some efficacy for better tolerability and convenience. So do you see much role for 2-drug regimens in that population?
I do use 2-drug regimens occasionally, based on what I think is going to be the most toxic of the therapies. So, for instance, in a triplet, there's often dexamethasone. Sometimes in those 80-year-olds plus, they can't tolerate dexamethasone. They, in fact, may have confusion, difficulty sleeping, high sugars, et cetera, even blood pressure problems where I think they can't tolerate it. And yes, then I might just go with the IMiD and the CD38 antibody. And if they're really frail, I actually think almost everybody can just receive a CD38 antibody as a single agent. I think it's extremely well tolerated. They do have to get a little steroid initially to get over the infusion-related reactions, but I'll have them off steroids by 4 weeks after starting that CD38 antibody. How about you? What do you use in that scenario?
I totally agree with you. I do myself use a fair amount of single-agent daratumumab. Sometimes if I, after a month, see that the response is not achieving that desired level, or patients are starting to break through, at that point, I may throw in a lower dose of one of the other drugs. And in that case, it is often, again, pomalidomide. I tend to use the pomalidomide at 2 milligrams in this older population, especially right from the get-go. So I think that our approaches, I think, fairly align in that regard. In terms of other factors that we take into account, obviously the comorbidities of patients are important. Fortunately, in the early relapse setting, we often don't have to worry about diminished marrow reserve. But what are the other things that you often look at in terms of choosing your regimen?
I think a couple of the important ones. One is what their creatinine clearance is and what their kidney function is. I think some people need to have dose reduction of medications. I think the biggest one really is lenalidomide, is when they're on lenalidomide, you have to worry about what their creatinine clearance is. And I usually start low, like you said, on some of these agents and go up if I can, as long as their blood counts can tolerate it. The second is blood counts. After several lines of therapy, the blood counts begin to become problematic. But I think we need to use growth factor support, and we need to use Neupogen as needed, Epogen as needed, and you can even use a platelet cytokine as needed for these patients. And the biggest one in my mind is mental status. I do think the IMiDs affect the mental status as people get older, and for sure the steroids affect the mental status. And I think that we have to watch closely. And lastly, the neuropathy. I do think bortezomib, it's hard to use a lot of bortezomib after you've used it for the first couple of years, just because they do have neuropathy. And so I think you have to switch to non-neuropathic agents at that time.
I totally agree. So I think we see here that there are a number of patient-related, disease-related, and other factors that we have to take into account. So we are already personalizing our therapies in multiple myeloma, I guess. Thank you, Tom. It was a great discussion, and I think that we are hopefully going to see major advances that will change how we practice in early relapse setting in the years to come. But yes, it'll get even more challenging as to how to choose our treatments, I think.
Thank you very much.
Thank you.
Remember, to receive your credit and evaluate this program, please visit morningcommutepodcast.com/multiple myeloma 1. For all the episodes in this 6-part series, please visit morningcommutepodcast.com/multiple myeloma. Thank you for joining us today.